Hi everyone, thanks for listening to all my presentations. Today I'll be talking about liver failure, but I'll be limiting myself to the treatment only. And why that? It's because the first presentation on liver failure, there I have covered the symptoms, the causes, how to make the diagnosis of liver failure, and of course the differential diagnosis of liver failure. So today I'll be limiting myself to the treatment only. If you haven't listened to the first presentation, please kindly check my channel right now and listen to it, and come back and listen to this one so that you'll be able to match the two and have complete picture. The best treatment in the face of liver failure is what? Liver transplantation. Why that? 40% of individuals with liver failure will recover without the requirement or the need for liver transplantation. But get it, more people, a larger proportion, a larger percentage, 60% will need liver transplantation. That is pretty high. So we have to seek referral as quickly as possible to a specialized center for liver transplantation. This is a serious matter. Severity of the liver failure will determine whether we will need intensive care unit management or we will not. So if the patient is going to be admitted in the hospital for treatment, the rooms should not be so bright, okay, and should be quiet. Then we'll go over the history and the physical examination and the lab reports again, including radiological reports. We'll go over everything. Now, when we check through the liver enzymes and we discover that the liver enzymes are dropping right now, we might be dealing with probable three scenarios. One, it might be that this patient is actually improving, the situation is getting better, or this patient has overcome the injury and is now recovering, or can be the bad one. And what is that? It can indicate that we are dealing with a situation that is getting out of hand. It's getting worse. How are we going to know that? It's likely that the decreased value of the enzymes are actually pointing to the fact that the liver hepatocytes are grossly down. They have been destroyed, that they have little left to produce the enzymes. So when we see that AST, ALT are dropping, we should not raise the hope of family members, telling them, oh, situation is good right now, AST is dropping, ALT is dropping. No, it might be that the liver is tired, cannot shoot out the enzymes again because hepatocytes are down. There are less hepatocytes to get the enzymes from. And this is like a child with asthma, wheezing. The mother and father could hear, and at a point the child is tilted to silent chest, and they'll say, oh good, oh she's calm now. No, she's not calm, she's about to die. You can give IV fluid normal saline if there is decreased blood pressure, and you can give IV fluid have normal saline 0.45 with sodium bicarbonate if you are dealing with acidotic environment. We can give dextrose for hypoglycemia and vasopressin if the IV fluid will not be able to raise the blood pressure. You may choose norepinephrine for the same purpose that you have used vasopressin. If the above is not enough, then we have to check for adrenal failure. We can check for adrenal failure by going through the history again and having a cortisol level at the appropriate time. You know when to take it. You can check my channel for that. I have full presentations on adrenal insufficiency. I think about 3 or 4 of them already published. And you can have ACTA stimulation test done. So if you are able to make the diagnosis of adrenal failure, then use your hydrocortisone. N-acetylcysteine could be useful, very, very useful in the face of acetaminophen toxicity. I have published a separate presentation on N-acetylcysteine already. Check my channel for that. You may make use of omeprazole per oral if there is gastrointestinal bleeding with or without blood transfusion, depending on the level of blood loss, or the anemia has already set in and is decompensating. Remember, why are we going to get bleeding here? Remember when we had the diagnosis in the first presentation, then we checked for PT and APTT, right? That all clotting factors are produced in the liver except 2, and those 2 are factors 8 and von Willebrand factor. So if the liver has failed and there is high INR now and there's bleeding, then give omeprazole per oral if there is gastrointestinal bleeding, and you may choose to transfuse if you think that more blood has been lost, anemia has set in, then make that determination. If there is ascites, our paracentesis down. In case you are suspecting spontaneous bacterial peritonitis, you are right. In liver cirrhosis, you should suspect that. You may use antibiotics prophylactically, but it is better to have blood culture done before giving the antibiotics. Remember, this liver is weak right now. You cannot just take all insults because there's less to help with the first pass when you give these antibiotics per oral, then you choose IV route, right? Antibiotic prophylaxis is controversial. I agree that it would be because you don't want to load the system with a lot of things anymore. So don't use severe protein restrictions. So have a reduction to 60 grams per day of protein, and that would be good enough. Okay. Avoid sedatives. As a matter of fact, you can just write by the bedside, no sedatives of any sort, because it might not be on duty when your patient will need something to handle insomnia or anything like that, and then one colleague on duty who has not seen the patient can just answer on the phone, oh, give lorazepam, give benzodiazepine, diazepam. No. In seizures, give low dose benzodiazepine or barbiturates, but don't give opioids. Why that? Opioids can decrease seizure threshold. Avoid nephrotoxic drugs. Why that? Because you might be dealing with hepatorenal failure. Okay? And look for and treat underlying cause or causes. You can check my channel for the treatment of hepatitis A, B, C, D, and E, and also for a full presentation on N-acetylcysteine for acetaminophen poisoning. In case of mushroom poisoning, you can use activated charcoal, silibinine, and penicillin G. In Budd-Chiari syndrome, you should not waste your time, just call the surgeons and go for transjugular intrahepatic photosystemic shunt. In herpes virus infection, you are free to use acyclovir. In wheezing disease, check my channel for that, but I'm pretty sure you are going to use penicillamine for the rest of his life. N-acetylcysteine can also be useful for other purposes, even if it is not acetaminophen complication. If you have done all, you are likely going to be faced with possible complications like metabolic derangement with decreased glucose, decreased potassium, decreased sodium, and decreased phosphate. You might be faced with hepatic encephalopathy and cerebral edema. You might be faced with seizures, hepatorenal failure, bleeding, pulmonary edema, and infection. Note, the cure is still the same, liver transplantation. And with that, I've come to the end of this presentation. Remember to leave your comments. Remember to share. Remember to subscribe to my channel so that you can get all my presentations immediately they are published. I appreciate it.